Hello, welcome. This talk is about spontaneous abortion. We're going to go over definitions, management, and also talk about recurrence a little bit at the end. So as a disclaimer, this is just health information for education and thinking about. It's not meant to be a guideline for treating anybody or for treating yourself. If you have a problem, make sure to take care of yourself and go see a medical person. All right, so getting into this. So definition, spontaneous abortion, what is it? Or also called a miscarriage. That's a loss, and that's less than 20 weeks. If you have a loss greater than 20 weeks, then it's called something different. It's called a stillbirth. The spontaneous abortions or miscarriages are broken up into a bunch of different categories. So there's a lot of terminology and definitions. We're going to go over those right here. We're going to make it fairly easy to remember because we're going to use two variables to classify these. So one is change in cervix, one is change in products of conception, the passage of it or not, and then that divides up all the categories. So there's missed abortion, inevitable abortion, incomplete abortion, and complete abortion. All right, this can be in the first and the second trimester, but it has to be less than 20 weeks. Starting off with missed. All right, that's when everything is closed and still inside. So cervix closed, products of conception retained. Inevitable, now the cervix is open, but the products of conception are still retained. Incomplete, cervix remains open, products of conception have partially passed. And then complete, cervix is closed down again, the products of conception is fully passed. Right? So complete is essentially the end. If this process were just to occur without problems, naturally no intervention, it would end up with a complete abortion. And this is a somewhat common thing. Up to like 20 to 25% of pregnancies, if you knew about all of them, would end up as a spontaneous abortion. Now, threatened abortion is another type that kind of gets lumped in together with these other ones, but I want to keep it separate because I think it's very different, and I'm not sure why it's usually put together. So threatened abortion is bleeding during this period. Okay, vaginal bleeding during this period, but it's not necessarily ending with fetal demise and abortion. As with all of these, that's the end result. From missed up to complete, fetal demise and abortion is happening. Whereas threatened, that's not necessarily the case. Right? The cervix is closed, products of conception haven't passed. You might have an increased risk in the future of problems like preterm labor or PPROM, premature preterm premature rupture of membranes. But there's not necessarily going to be an abortion happening. So I kept that separate there for that line. All right, and so now we're going to go over to management. So for treating these patients, there's two groups. So missed, inevitable, and incomplete all go together in terms of management. And there's three ways to manage these issues. So there's the expected management. That's usually early on, first trimester, stable patient, no sign of infection. And that's you're essentially letting the sort of nature take its course type of a thing. Okay, so let's say you have someone who is inevitable. They have an open cervix, but the products of conception are retained. You're just waiting them and following until they go to complete. Same thing with any of these steps: missed to complete, incomplete to complete. And that can take up to several weeks, and you have to educate the patient on what to expect and follow up with them. Okay, you can also do medical management, and that's using misoprostol. You can sometimes add mifepristone to that, but misoprostol is the mainstay of treatment. And what does that do? That's a prostaglandin analog, PGE1 analog. So you give that, it causes dilation, cervical thinning, and stimulation of uterine contraction. So essentially induces delivery of the aborted fetus. Mifepristone is a progesterone receptor blocker. That can be added sometimes as well. And surgical management involves dilation and then mechanically removing the products of conception. Right, so you can do dilation and then curettage. That's the scraping tool, or dilation and evacuation, which is more of a tubal suction sort of tool. Then over here, when you get to complete, what the management is not a whole lot, because this process is gone. It's completed. The cervix is now closed. Products of conception are all gone. You follow the patient. You can send products of conception to pathology if they're available. Maybe if this is a recurrent problem for the person, to get karyotyping and more information. You also want to look for signs of infection. You don't need a very active set of management in the case of a complete abortion if there's nothing that's making you worry like an infection. In threatened abortion, what you do there is you do like NPO. If someone's going to surgery, nothing by mouth. You do NPV, so that's nothing per vagina. In the future, like we said, they're set up for having a greater risk of preterm labor or preterm premature rupture of membranes. And this is a bleeding event, They have to get RhoGAM if they're Rh negative. All right, so now we're going to talk a little bit about, because less than 20 weeks, that's a big time frame. The difference between 10 weeks and 20 weeks is significant. So first, when you're talking about these spontaneous abortions, you divide them generally into first trimester and second trimester. So first trimester, it's just common. Sometimes people don't even really notice that it happened. It's like thought of as maybe a late period, and these are mostly due to chromosomal abnormalities. So the second trimester, so that's from 12 weeks up to 20 weeks. So in general, this is not as much caused by chromosomal abnormalities. It can be caused by anatomic defects. In the mother, for example, the uterus or cervical insufficiency can be caused by infection, trauma, preterm labor. All right, and so there's two that need to be looked at a little bit closely. And so one is preterm labor. All right, and so tocolysis, which will be stopping the preterm labor in less than 20 weeks, is not strictly indicated according to recommendations, because tocolysis works for a maximum of about 24 hours. And so the question then gets asked, well, what good will this do to delay this for 24 hours? And someone who's less than 20 weeks, it's not going to do a whole lot of good. So that's why it's not strictly recommended. Although that doesn't mean it never gets used. And then also when you're looking at preterm labor, it can be a little bit difficult to distinguish from incompetent cervix, right? So you see that there's a cervix that's dilated, that's larger than it should be, and you're wondering if it's preterm labor or not. So if there's contractions that have been happening, painful contractions before the cervical change, then you think, okay, that's preterm labor, as opposed to incompetent cervix. Then you're looking at more painless dilation and effacement. Right, and then one of the main problems with the incompetent cervix, in addition to not being able to keep the pregnancy in the uterus, is that you get exposed to infectious agents, and also you're more exposed to trauma. All right, so second trimester, you're more likely to be due to anatomic things, infection, trauma. Incompetent cervix, less likely to be a chromosomal abnormality, although chromosomal abnormalities can certainly cause spontaneous abortion in the second trimester. And then two things you want to look at specifically are preterm labor and incompetent cervix. All right, so just some notes on second term. There's increased rate of complications. So what are the complications that we're concerned about? Infection, retained products of conception, hemorrhage. Those are the big concerns here. And in general, so if you have a late second trimester abortion, you bring the patient into the hospital, get misoprostol for induction, and then if the products of conception are not all delivered with that, then you can use a surgical removal. So that'd be a D&C or D&E. Since now that it's further along, there's more dilation that's needed, and there's a greater risk in doing the operation. A big risk would be perforation. So when you dilate, you have to lose laminaria, which are like those little seaweed sticks with a string on the end. So you put the end of the cervix, and the seaweed so absorbs the water, gets bigger and dilates. So those are some of the things that you need to use. So usually, in induction with misoprostol is tried initially, because hopefully that'll deliver all the products of conception. Then you won't need any sort of surgical intervention. All right, so a little bit more on the incompetent cervix, because that's sort of its own topic. And so to get a good definition of this, we already kind of touched on this from the sides, like that it's not strong enough to hold the pregnancy in the uterus, and that's right. And this is a very good definition of it. So it's the cervix cannot retain a pregnancy without the signs or symptoms of labor, contractions, in the second trimester. So the cervix can't hold a pregnancy in, you're in the second trimester, and it doesn't seem like there's labor going on, right? So that excludes preterm labor. That's the definition of it. And this can be a recurrent cause of spontaneous abortions in the second trimester. All right, we said that we have to differentiate it from preterm labor. We talked about how to do that, right? You're not seeing the contractions preceding the cervical change. You have painless cervical dilation. And the risk factors that could lead to this happening are any sort of damage or manipulation of the cervix, so prior mechanical dilations, prior possible surgeries for maybe cervical cancer, or just having a short cervical length, right? We're all in a normal curves, and some people have shorter cervixes than others, and that's a risk factor as well. So to diagnose this, the number to remember is this: a cervix is less than 25 millimeters, puts you in less than the 10th percentile. Or if you see advanced cervical change in the second trimester, and then somebody has a history of spontaneous abortions or preterm births, prior child is spontaneously aborted, or preterm birth, or they have risk factors, surgery or mechanical dilations. This is a just a little typo. It's supposed to be history of SAB, not SAM. And the treatment for an incompetent cervix, mainstay is cerclage. So there's emergent cerclage, and that's if you didn't really realize that this was an issue going on, and then the person's pregnant, and they want to continue the pregnancy, and you're saying, what can I offer? You can put in a cerclage, or it can be done electively if you know, if you're kind of expecting that this is going to be a problem from prior experience with this patient, then you can put it in electively. There's also expectant, which is kind of like wait and see, or an elective termination. And cerclage is an operation essentially suturing around the cervical vaginal border, or you can suture at the internal os, and you keep those sutures in until 36 weeks. You take them out, and then you deliver the baby that way. So essentially, it just holds the fetus in until it's time to deliver. There's a very high success rate, greater than 80%, using cerclage to treat the incompetent cervix. All right. So by way of review, all those spontaneous abortion definitions. Okay, so remember, there's two parameters. There's the cervix, and there's the products of conception. All right, so starting with missed abortion. Right, closed, products of conception are retained. Inevitable. Now the cervix is open, products of conception are still retained. How about incomplete? Cervix continues to be open, but the products of conception are now partially passed. And incomplete, cervix is closed, and the products of conception have passed out. So they're gone now. So the process is completely done. What about threatened? So the cervix is closed, the products of conception are still there, and there's bleeding, vaginal bleeding, in the first trimester. Okay, those definitions, and they're kind of tricky and annoying, but I think if you look at them on those two lines of cervical change and products of conception in that order, it's pretty easy. And then so the general types of treatment. So we group together which three ones: missed, inevitable, and incomplete together for treatment. And then you can go expectant, just see what happens, see if it progresses. Medical, mainstay of medical is misoprostol. Surgical, it's D and C, D and E. So if you have a late second trimester, spontaneous abortion, what's a good general idea for management? Have the patient come in, misoprostol, follow up with surgery if necessary. And the reason behind that is that you have greater chances of complications, infection, hemorrhage, retained products of conception. And then what do you want to rule out or sort of investigate further in second trimester? Since it's not, the chromosomal abnormalities have decreased a little bit, you want to make sure that you've thought about preterm labor and also incompetent cervix. Right, and so the incompetent cervix specifics, what length, if you saw on a transvaginal ultrasound, the measurement of the cervix would make you worried about incompetent cervix. 25 millimeters, less than 25 millimeters. And the treatment, mainstay is cerclage. So now we've done a few of these talks now, so we can make a little bit of differential for first trimester bleeding. So from this lecture, we can put on there, right, spontaneous abortion, prior lecture, ectopic pregnancy, and those I think are the first two that should come to mind. Other ones are things like postcoital bleeding, vaginal lacerations, among many other types, but ectopic and spontaneous abortion should be right up there on the differential for vaginal bleeding. All right, and then finally, so this is the topic of recurrent abortions, and so probably one of the most important things is, when do you look into this actually? And so when you look into it is when there's been greater than 3 prior and they've been consecutive spontaneous abortions. That's when you start to look into it. There's a bunch of different problems or causes, and then potential treatments. So chromosomal abnormalities, you can treat that with IVF, right? You can use a donor sperm, a donor egg, or you could also use the couple like coming in, but then you can try to select out the ones without chromosomal problems. Hypercoagulability, sort of weak evidence in general associating this with this problem, but you can try heparin. The incompetent cervix, we talked about that with cerclage. So phospholipid antibody, and so sometimes what that is confusing. So that's associated with lupus, and it's a hypercoagulable thrombophilic type state. And so that's the antiphospholipid antibodies, like the big term for having antibodies that make you thrombophilic, usually associated with lupus. And then there's two more specific things you can look for, which are anticardiolipin and the lupus anticoagulant. So those are things that you can test for to support the diagnosis of antiphospholipid antibody. But anyways, if you have that, that's can be a cause of recurrent abortions. You can treat that with aspirin. And there's luteal phase defect, which is sort of another weak evidence thing, kind of like hypercoagulability. The idea there is that you're supposed to have fertilization, and you're supposed to have the blastocyst with its trophoblast and primitive placenta that's developing make beta-HCG stimulate the corpus luteum to make the progesterone and estrogen initially, right before the placenta takes over production for the first trimester. So luteal phase defects are saying that there's something wrong with that corpus luteum and it can't make the progesterone to maintain the pregnancy, and so you could try to give somebody progesterone. And other things that are important to look up or to do in this recurrent abortion, spontaneous abortion evaluation is thyroid, so hypothyroid, and also evaluation of the structure of the uterus. For example, hysteroscopy, hysterosalpingogram, sonohysterography, and things like that. Right, and so thanks for watching this talk. You can visit the website at procedureready.com for more right there, and then to consider checking out 52kids.org. Making a donation. Thanks for watching.